Hello, today we will talk about the introduction, overview, pathophysiology, and the management of aortic regurgitation. Aortic valve are present between the left ventricle and aorta. In regurgitation, these aortic valve does not close during diastole, which leads to a blood leak back from the aorta into the left ventricle and cause a progressive ventricular dilatation to accommodate the increase in the blood volume. Note that this condition often occur in individuals who are more than 50 years old. There are two major etiologies of the aortic regurgitation. The first one is disease of aortic valve. Here we can see an aortic valve which is calcified and not closed properly and will lead to regurgitation. And the second is distortion or dilation either of the aortic root or of the ascending aorta. Aortic regurgitation which occur due to valve disease include the rheumatic fever, which is the most common cause in the developing countries, calcific valve disease, infective endocarditis, and connective tissue disorder including rheumatoid arthritis and systemic lupus erythematosus. While aortic regurgitation which occur due to aortic root disease and this account for almost 50% of the causes include the aortic dissection, spondyloarthropathies including ankylosing spondylitis, hypertension, syphilis, and connective tissue disorder including Marfan syndrome and Ehlers-Danlos syndrome. The bicuspid aortic valve affect both the valve and the aortic root. The valve leaflets may be normal or abnormal, but they are stretched apart due to the dilatation of ascending aorta. The abnormalities of the valve leaflets may be seen as the thickening of valve, calcification, vegetation, and prolapse or flare leaflets. Here is the partially prolapsed aortic valve. The types of the aortic regurgitation, and note that these are the functional types. Type 1 include the functional aortic calcification, which can occur at the aortic annular, aortic sinus or at the root, and the cusp perforation. Type 2 include the cusp prolapse, which could either be complete prolapse or a partial prolapse. Type 3 include the cusp retraction, and this retraction leads to the shortening of cusp. There are other types of the aortic regurgitation which lead to the calcification. The wide range of sign and symptom of aortic regurgitation due to various etiologies include the tachypnea, tachycardia, orthopnea, exertional dyspnea, paroxysmal nocturnal dyspnea, palpitation, and fainting. On physical examination, the aortic regurgitation cause a collapsing or a water hammer pulse. And to check this pulse, the patient has to lie back and raise the arm vertically upward, and the examiner has to grasp the muscular part of patient's forearm. The water hammer pulse is felt as a tapping impulse that felt through the bulk of the muscle because the blood that is pumped to the arm during systole is now emptied back into the heart during diastole due to the effect of gravity of the raised arm. Normal pulse pressure is systolic minus diastolic. But the distance between the systolic and diastolic pressure is increased now, referred to as the hyperdynamic circulation, forming a wide pulse pressure. Another finding is Quink's pulsation, and it is when the nail is pressed down, there is a pulsation in nail bed. De Musset sign is when the individual bob or nod the head with each heartbeat. Hill sign refer to the significant difference in the systolic blood pressure between the upper and lower limb, and the popliteal systolic BP is at least 40 mm above than the brachial systolic blood pressure. Auscultation is done by placing the stethoscope at the left third or fourth intercostal space parasternally when the patient is sitting or in a leaning forward position. An early diastolic decrescendo murmur is audible, which is due to the backflow of blood through the valve. This is low in intensity, high in pitch and blowing type of murmur. And since there is more volume into the left ventricle now, when it contracts there is also ejection systolic murmur. In severe aortic regurgitation, there is a mid-diastolic Austin-Flint murmur, which is due to the partial closure of anterior mitral valve cusp caused by the regurgitation stream. The severity of the aortic regurgitation can be determined through the chest X-ray, which may show a left ventricular hypertrophy, or by performing a echocardiography or a cardiac MRI, which specifically look at the volume of blood flowing back into the left ventricle with each heartbeat. As for the treatment, no drug can delay the progression of aortic regurgitation. And the mainstay of treatment is aortic valve surgery, which is indicated in severe aortic regurgitation. Those individuals who does not have severe aortic regurgitation, or even if they have severity but does not cause left ventricular dysfunction, this surgery is not recommended. Instead, angiotensin converting enzyme inhibitors, angiotensin receptor blockers are given, and nifedipine, which is a vasodilator, is added in those patients who have hypertension. All of these medications increase the forward flow of blood but do not delay the progression. Surgical valve replacement is indicated if there is acute valve rupture, as with the myocardial infarction, in which the replacement or repair of the valve is performed before the left ventricle dilates excessively, and while the ejection fraction is still greater than 55% and the ventricular end systolic diameter is less than 55 mm. Repairing of the valve means that tightening the end of the valve with the suture. This will decrease the regurgitation without the need of anticoagulations. Those individuals who have severe aortic regurgitation with left ventricular impairment and their surgical risk is low, the aortic valve surgery is recommended. Alternatively, those patients who have a concomitant disease of another valve, aortic valve surgery is recommended independent of the severity.